Welcome to the first presentation in a three-part series about screening for sexually transmitted diseases. My name is Shannon Connolly, and I'm a practicing family physician, educator, and STI screening advocate. I'm here with my co-host, Dr. Scott Hartman.
Hi, I'm Scott. I'm also a family physician, educator, and STI screening advocate.
Scott, today's podcast is focused on how to take a good sexual history, something that's really important in understanding a patient's need for screening, but also something that a lot of clinicians have trouble doing. Why do you think that's the case?
Well, I think that just like patients, clinicians have all sorts of challenges when it comes to talking about sex. Some of us were raised to believe we shouldn't talk about it, and some of us feel a little panicky when it comes up during a visit. It can feel awkward. Sometimes patients tell us things about their sex lives and we're just not sure how to respond. I didn't go over that in medical school. And other times we're afraid that it will make the patient uncomfortable if we ask a lot of detailed questions about their sex lives.
But you know what? Patients actually do want us to ask. Moreira and colleagues found in their international study of over 27,000 people that patients want their clinicians to ask them about sexual concerns during routine physical exams. Another study published in the journal Clinical Pediatrics found that most adolescents feel it's important to discuss sex, contraception, and STIs with their healthcare providers. I think another thing that's a real life everyday issue is time. Most doctors are so strapped for time that adding anything else to an already packed 15-minute encounter can feel overwhelming. But if you get good at it, you can take a sexual history very efficiently without adding too much time. And just like with any other clinical skill, we can learn and practice and become confident at it.
And it's really important that we as clinicians become facile with talking about sex, because if we aren't able to guide a conversation about it, we're going to miss out on important opportunities to provide good care to our patients. We can't just wait for a patient to bring it up. They may never do so. It's on us to know how to ask and elicit concerns so we can respond. This is especially true when it comes to screening for sexually transmitted infections, because if you don't know about a patient's risk factors, you can't possibly screen appropriately.
And screening is really important right now because for the last decade, we've seen an alarming national trend of increasing rates of most STIs. Remember that a lot of STIs can be asymptomatic for a long time, meaning that someone can have an STI and have no idea, unknowingly transmitting the infection to other people. That's why screening is essential. As someone who works in the area of sexual and reproductive health, I'm really concerned about what we're seeing with rising rates of syphilis, particularly neonatal syphilis. We're also starting to see more cases of azithromycin-resistant gonorrhea. So we have to do a better job of screening. And before we can screen, we have to figure out who we should screen and how. And to do that, you have to know some information about the patient. Scott, I know you train a lot of medical students and residents. When you introduce the idea of taking a sexual history, where do you start?
Well, I think before you even start to talk to a patient, it's important to do a little self-reflection and recognize that we all have our individual biases. And there's tremendous diversity in human sexual behaviors, practices, values, and beliefs. Just like with anything else, it's really important to check all those biases at the door and approach the encounter in a neutral fashion. You want to be clinically curious so you can fully understand the patient's experience, but you also must be open and non-judgmental. Otherwise, the patient may not feel comfortable telling you things.
That is so true. And it's also really important to never assume you know what a patient's sex life is like. Patients are gay, straight, cisgender, trans, bisexual, scoliosexual, polyamorous, asexual, kinky, monogamous. You get the idea. Please don't assume all of your patients are heterosexual, cisgender, and monogamous. You will fail your patients if you enter an encounter with that assumption.
Also, it's important to familiarize yourself with the vocabulary that patients may use to describe their sexual practices. Otherwise, you might not be picking up on important information. If the patient says something you don't understand, it's okay to ask politely for a clarification.
I will never forget a situation I once had where I left a clinical encounter with the understanding that my patient had just told me that she worked in a cafe, whereas the patient was under the impression that I was now aware that she was a sex worker. Luckily, my nurse was a little bit more savvy than me and helped me understand things a little bit better.
I think we all have a story or two like that. So let's talk about how to set the stage for taking a sexual history. How do you do it?
Well, Before you launch into a sexual history, there are two very important things that you have to do, and you can do both of these things in just a few seconds. The first is you have to explain to the patient why you're asking, and the second is you have to ensure confidentiality. So, for example, it would generally not be appropriate to ask a sexual history with a patient's partner or family member present in the room. So, Scott, let's pretend you're a patient and I'll model it.
All right.
Hi, Scott. I'm going to ask a few questions about your sexual history. I ask everyone these questions as they're important to understand your health. Everything you tell me is confidential.
Okay, that's fine.
And here's an important side note on confidentiality, especially if you care for minors. You have to explain mandated reporting. Laws vary by where you practice, but I usually say something like, everything you tell me is confidential with one notable exception. If you tell me that you're in danger of harming yourself or that someone is harming you, I'm required to involve someone else to make sure we can address that. Make sure that you know your local laws regarding things like the age of consent, because that can vary from state to state.
I also want to highlight an important aspect of all healthcare, but especially as it relates to sexual health, trauma-informed care. Many of our patients have experienced abuse and sexual trauma, and this can come up when discussing sex. Unfortunately, sexual trauma is so pervasive in our society. You have to always be aware of the possibility that your patient has been affected and create a supportive, safe spaces where patients can disclose it and you can help connect them with resources they need.
Thanks, Scott. Really important points. So now that we've taken the time to consider our own biases and set the stage for the patient, how do we actually take a sexual history? Well, the CDC recommends a framework called the 5Ps.
Those stand for Partners, Practices, Protection, Past History of STIs, and Prevention of Pregnancy. On the slide here, you can see a table adapted from the CDC with examples of questions from each of these categories if you're on the webinar. If you're on the podcast without visuals, please check out A Guide to Taking a Sexual History, which is a free online publication put out by the CDC. I like this list of questions because if you ask them, you'll get a really good understanding of a particular patient's sexual behaviors and risk factors. This will help you identify areas for behavioral and risk reduction counseling, as well as guide your screening. The wording of these questions is also neutral and non-judgmental, which is very important.
Scott, I'm so glad you said that because your language as a health care provider is so important. And here's a tip. I recommend that you take the sexual history in exactly the same way with every patient. That way, you have a script in your head that you're following using language that you've already thought carefully about and vetted, and you aren't as likely to accidentally insert your own biases. Generally speaking, standardizing your approach ensures that you are delivering the same quality of care to each patient.
You should also spend some time thinking about how you phrase questions, so you're remaining neutral and open to any answer. For example, instead of saying, "Are you married?" you might instead ask, "What is your relationship status?" Or instead of saying, "Do you have a lot of sexual partners?" you might instead say, "How many sexual partners have you had in the past 12 months?"
Scott, why don't we model what this conversation might actually look like? We'll run a timer while we're modeling the sexual history taking so our viewers can see how quickly you can take a good sexual history. Do you want to be the doctor?
Okay, sure.
Then I'll be the patient. My name will be Isabel, and I'm a 23-year-old cisgender woman coming in for a pap smear.
Hi, Isabel. Thanks for coming in for your PAP. If it's okay with you, I'd like to ask you a few questions about your sexual history. I ask everyone these questions because they're important in understanding your health and whether we should do any tests. Everything you tell me is confidential.
Okay.
Have you ever been sexually active?
Yes.
And what is the sex and gender of your partner or partners?
I have sex with both men and women, but I'm currently in a relationship with a guy.
Okay. And how many partners have you had in the last 12 months?
6, I think. Yeah, 6. My boyfriend and I sometimes see other people.
Okay. And how well do you usually know your sexual partners?
Pretty well. I don't have sex with someone unless I've gotten to know them. I don't do drunk hookups anymore, Doc.
Do you ever have sex while using drugs or alcohol?
Not anymore. When I was younger, maybe.
And have you ever used IV drugs?
Oh, no, nothing like that.
Okay. Do you remember when the last time was that you had any testing for sexually transmitted infections?
It's probably been more than a year. Can I do that today?
Of course. Just let me ask a few more questions that'll help us decide what kind of tests we should do.
Okay.
Do you have vaginal sex? What some people refer to as penis and vagina sex.
Yes.
And giving or receiving oral sex?
Yes, both.
And anal sex?
Yes.
And other genital contact or sharing sex toys?
Yep, that too.
Okay, thank you. Knowing what type of sexual contact you have helps me know where anatomically we may need to do testing. Isabel, when you have sex, do you ever use anything to prevent pregnancy or to prevent sexually transmitted infections?
Well, with my boyfriend, we don't use condoms because we've been together for a long time, but we both use them when we have sex with other people.
And have there been any times where you haven't used a condom when having sex with other people?
Well, yeah, when I'm with a woman, I guess. I should probably be more careful, huh?
We can talk about ways to have safer sex when you're with a female partner. It's important to think about regardless of the sex of your partner. So also, have you ever been diagnosed with a sexually transmitted infection?
Yeah, I had chlamydia when I was a teenager. Nothing recent, though.
Okay, and what about your partners? Do you know if any of them have been diagnosed with a sexually transmitted infection?
Not that I'm aware of.
Okay, and what about pregnancy? Do you have any concerns about that?
When I have sex with my boyfriend, he pulls out to prevent pregnancy. So far, that's been working okay. I always use condoms with other guys.
Okay, and if you were to get pregnant, what would that be like for you right now?
Um, Not good. I'd rather not get pregnant. Now that I'm saying that out loud, I might need help with birth control too.
No problem. I can definitely help you with that. Last question before we talk about birth control. Do you feel safe with all of your partners? Has anyone made you feel unsafe, threatened you, or harmed you in any way?
Yes, I'm safe. Thank you for asking.
Okay, so that was a pretty standard sexual history. That took under 3 minutes. What was that like for you, Shannon, as a patient?
It was good. I think your comfort with the questions and also the way you didn't react to any of the answers made me feel like it was no big deal to talk about these things. What was it like as a doctor?
Well, it was helpful to think about the 5 Ps as I went through all the questions so I could make sure we were covering everything. My doctor brain saw so many opportunities to do education and counseling in there. I wanted to talk to her about safer sex, about HPV vaccination, maybe about HIV pre-exposure prophylaxis. There was a lot, but I'm glad that Isabel identified a contraceptive need for herself and we were able to address that today.
And certainly taking on any of those topics would be great. It just goes to show how much opportunity we have to address the sexual health needs for our patients when we start to take better histories.
For sure, we learned so much about Isabel. We learned about her risk factors, her sexual practices, and we also learned about things like what anatomic sites we should screen for STIs.
Yep, and that is a really important clinical pearl that I try to teach my trainees. You have to screen where the potential contact occurs. So if someone only has receptive anal intercourse, it makes no sense to screen their urine for gonorrhea or chlamydia. That person needs a rectal swab for appropriate screening.
So we're going to talk a lot more about different test types and indications for testing in our next episode, which will focus on testing recommendations for specific populations.
We hope that this episode was helpful in getting you to think about how to take a good sexual history, and specifically how to start the conversation and how to phrase questions in ways that are straightforward, non-judgmental, and easy for both you and the patient. Remember, it gets easier with practice, and you should practice a lot because you should be asking these questions with most of your patients.
That's right. Thanks for joining us, and we'll see you for our next installment, which goes over screening guidelines for specific populations. See you next time.
Welcome to the second podcast in our three-part series on screening for sexually transmitted diseases. My name is Dr. Shannon Connolly, and I'm a practicing family physician, educator, and STI screening advocate. I'm here with my co-host, Dr. Scott Hartman, a fellow STI screening superhero.
I am Scott, and as Shannon said, I'm her co-host, but also very interested in STI screening because we're just that nerdy.
Scott, since last time we discussed how to ask screening questions, in this session, we'll use a few illustrative cases to discuss evidence and or guideline-based screening. So for the first case, we'll assume we've already started a patient encounter and taken a thorough and appropriate sexual history. Here's what we have found.
Patient AJ is a 28-year-old pregnant patient presenting to the health center at 9 weeks gestational age for initial prenatal care. AJ identifies as heterosexual cisgender female with a history of 5 partners in her lifetime, both female and male. She endorses currently being monogamous with a male partner for the past 12 months. She denies a history of any sexually transmitted infections, last testing about 1 year ago before meeting her current partner. She denies vaginal bleeding, pelvic pain, dysuria, fevers, or vaginal discharge. So Shannon, let's jump right in. According to the Centers for Disease Control, or CDC, what screening lab should we recommend for AJ?
Well, outside of prenatal labs such as blood type or anemia testing, the CDC tells us we should strongly recommend screening for HIV, hepatitis B and C infection, and syphilis. The USPSTF echoes those recommendations for universal screening at the initiation of prenatal care. In certain patient populations, the incidence of this may be very low, but undiagnosed cases of these particular infections can cause great harm to a fetus or newborn, so universal screening is recommended. For those of you looking at the slides, Table 5 lists all of the STI screening for people who are pregnant. It summarizes what we just discussed.
And if I may, I'll add a few nuances to that. So first, the Hep C screen is a very new recommendation that appeared in 2020. Although USPSTF and the American Academy of Family Physicians advise risk-based screening for chlamydia and gonorrhea in pregnancy, many American offices or health centers that provide maternity care recommend these screenings universally. In some ways, it's more streamlined to just screen all patients. This patient is over 25 years old, but has had no testing since being with her current or new partner. So she should be offered gonorrhea and chlamydia screening. Lastly, we should mention that listeners can refer to the USPSTF or the American Society of Colposcopy and Cervical Pathology, ASCCP, for evidence-based guidelines on when to offer Pap tests and HPV screening. There's not a pregnancy-specific cervical cancer screen, but per ASCCP, if under 30 years old and no Pap in the last 3 years, she could have a Pap at the beginning of pregnancy.
Also important to point out is that gonorrhea and chlamydia screening can be performed at a number of different anatomical sites, and the decision of where to test should be guided by the patient's sexual practices, specifically which parts of the patient's anatomy have had sexual contact. So you might choose to screen via a pharyngeal swab, a rectal swab, a vaginal swab, a cervical swab, or urine, depending on what kind of sex the patient has. Cervical swabs have to be clinician collected, and there's some evidence that pharyngeal swabs are more sensitive when collected by a clinician, but all the other specimens may be collected by the patient as long as the patients are instructed on how to self-collect. In doing a urine collection, it should be a regular catch urine, meaning patients should not wipe with towelettes or other materials before collecting the specimen. So Scott, if AJ told us that she has vaginal sex and oral sex, how would you screen for chlamydia and gonorrhea?
I would recommend pharyngeal testing because of her history of oral sex. And then because she also has vaginal sex, I would offer urine testing or a vaginal or cervical swab as well. So there's a lot more we can say about pregnancy, but in the interest of time, we'll move to case number 2. AM is a 34-year-old patient who presents to the health center for a health maintenance exam. AM identifies as a cisgender heterosexual male. He endorses a history of about 10 lifetime partners, both male and female, and currently has both a monogamous female partner and a male partner that he, quote, hooks up with occasionally, unquote. He endorses a variety of sexual practices in the past, but with his current partners, he endorses performing and receiving oral sex, as well as insertive and receptive anal sex with both partners.
So I'm hoping you've listened to part 1 of our podcast and remember all the tips on sexual history taking we gave you. You may recall that we really emphasized, at least for STI screening, a focus on actual sexual practices and body parts that patients have and utilize, rather than the terms they use to identify themselves. Although this patient identifies as a cisgender heterosexual male, he engages in practices with men and women, including receptive anal sex.
Given non-monogamy, he's someone that the CDC would tell us should be offered regular serial screens for HIV and STIs, potentially every 6 to 12 months. So these would include HIV, hepatitis B if unvaccinated, hepatitis C, syphilis, gonorrhea, chlamydia, as noted in Table 3 in the webinar, which compares the CDC and USPSTF recommendations. This table is taken out of the AAFP's STI screening manual, which is available for free download to anyone.
Here, site-specific testing is key. Testing for rectal, gonorrhea, and chlamydia is important for patients engaging in receptive anal sex, and this test would require a rectal DNA swab, or NAAT, which stands for Nucleic Acid Amplification Test. This cannot be accomplished via just testing urine. If you only test the urine of someone who is having receptive anal sex, you have not appropriately screened this individual. Similarly, with receptive oral sex, an oropharyngeal swab is necessary.
And lastly, for this patient, I would recommend that he be offered PrEP, HIV pre-exposure prophylaxis, given multiple partners and non-monogamy. Despite what you may hear on social media, PrEP is not just for gay and bisexual men, and it's important for all persons at risk, regardless of sexual orientation or gender identity.
And Scott, what about herpes? Should we also screen this gentleman for HSV?
Shannon, thanks so much for bringing this up because this is an important point. While many people think that HSV should be included in the list of STIs we screen for, that's actually not correct or not evidence-based. There's clear guidance by the USPSTF that we should not screen for HSV in asymptomatic adolescents or adults. There may, however, be a limited role for screening in patients who having a sexual partner with HSV.
This is because serodiscordant couples may wish to avoid sexual contact during outbreaks, or the positive partner may consider taking suppressive medication to avoid transmission to the negative partner.
It may seem counterintuitive to not routinely screen for HSV, but there are a few reasons why. HSV serologic tests have low specificity and a high false positive rate in asymptomatic individuals. The positive predictive value is only about 50%.
Also, serologic tests can't determine whether a person has an oral or a genital infection, and there are no treatments for asymptomatic individuals. A positive diagnosis of HSV can cause a lot of stress and anxiety, as well as disruption of personal relationships.
So that's why the USPSTF determined that the harms outweigh the potential benefits of screening.
So let's go to our final case. 19-year-old patient LM presents with concerns of vaginal discharge for 1 week with very mild pelvic pain, no hematuria or bleeding, no flank pain or fevers. LM identifies with they, them pronouns and does not identify with any specific gender. When asked what body parts they have, they endorse having had top surgery to remove breast tissue, but not bottom surgery. They possess a vagina, uterus, and cervix. They endorse having 5 partners in their lifetime, 4 male that were all more than a year ago, and 1 female with whom they are currently monogamous.
If I were this patient's primary care clinician, I would want to get to know them better and discuss things like their comfort with body parts. But purely from an STI screening perspective, we should focus on current risks and what testing would be most useful based on body parts and sexual practices.
We could offer the universal HIV and hepatitis C screening recommended for all adolescents and adults, but if this has already been done and the patient endorses no new risk factors, it may not be necessary right now. Given the pelvic pain and discharge, we should certainly offer testing for gonorrhea, chlamydia, and trichomonas, but also non-STIs like candida and bacterial vaginosis. This table is from the AAFP's STI screening manual, which is also available for free download to anyone.
We didn't initially hear from the patient what types of sex they're having, just monogamy. So we need to ask about oral, vaginal, and anal sex, and then insertive and/or receptive. Similar to the cases above, if concerns are purely vaginal, the gonorrhea chlamydia testing could be via urine, a clinician-collected cervical swab, or a patient-collected self-vaginal swab. Rectal swabs may be patient or clinician collected, as we said earlier, but keep in mind there's not great evidence regarding oral pharyngeal self-swabs. So we recommend that these be clinician collected. And just as a reminder, we're talking about swabs for nucleic acid amplification.
Thanks, Scott. Well, as you can see, there are a lot of considerations for STI testing. But if we were to distill it down to its most basic concepts, I would say that there are two rules for STI testing. The first is to use evidence-based guidelines and the partner's age, sexual behaviors, and risk factors to determine whether to test. The second rule is to remember to test the anatomic site that is likely to have had the exposure.
This concludes the second part of Quest Diagnostics' three-part educational series about STI testing. In our first session, we discussed how to take a sexual history. In this segment, we reviewed evidence-based guidelines for testing. We hope you'll also join us for our upcoming last segment, where we'll discuss strategies for implementing easy office-based screening, including operational considerations for specimen collection, EMR best practices, and optimizing the roles of support staff to meet clinical quality.
We'll see you then. Welcome back to our STI screening series, part 3. I'm Dr. Shannon Connolly, and I'm here with my co-host, Dr. Scott Hartman. We're both family physicians, educators, and big fans of evidence-based STI screening because we are super nerdy, but proud to be. In our first two segments, we discussed how to take a sexual history, as well as best practices for testing in specific populations. Today, we'll be talking about some barriers to STI screening in primary care and provide some troubleshooting ideas for practical implementation.
To learn more about how to improve evidence-based STI screening, in 2019, the American Academy of Family Physicians, or AAFP, surveyed 268 family physicians. They identified some key questions and barriers that family physicians experienced when considering STI screening. Specifically,
many family physicians wanted to know, how on earth do clinicians find time to address STI screening when the patient presents for something other than a reproductive health or preventive care visit? How do you shoehorn in one more thing when your patient is already due for their flu shot and their mammogram, and you need to talk to them about smoking cessation, but they're here in your clinic because they sprained their ankle?
very relatable.
Right? Family doctors also were concerned about convenient patient access to care, such as not having to travel to multiple sites, take lots of time off work, etc. And another big question was, how do we train staff to become comfortable with various patient populations and with STI screening in general?
So let's unpack that a bit and look first at staff preparedness. Putting this through a health equity lens, I would advise that all medical practices or health centers provide implicit bias training for all their clinical and non-clinical staff. This should include general concepts of implicit bias and cultural sensitivity, but could also include training in mitigating bias related to sexual orientation and gender identity. The AFP offers an excellent toolkit on their website through something called the Everyone Project, as you're seeing on the screen if you're on our webinar. The resources here are available for free to everyone, not just family doctors. You can find this toolkit on the AAFP website.
And beyond that, we'd recommend brief ongoing sessions for your practice or health center staff related to STIs. It's important to create a practice culture that is non-judgmental and welcoming of patients of diverse identities. It's also important for staff to be skilled at things like how to take a sexual history, lab collection methods, and even knowledge of STI treatment. There are many resources out there, but as in our last podcast, we'll give a shout out to the AAFP's STI Screening Manual, now showing on the screen if you're on the webinar. You can download it for free, and it's an excellent training aid for any clinical staff. We should also mention that scripting is key for all clinical staff, whether you're talking about medical assistants or nurses or physicians. Using standard scripts and asking the same question the same way every time creates objectivity and mitigates bias.
So let's move on to talking about time and efficiency. We've got a few tips for you here. Let's first start with patient questionnaires. As with things like depression screening, many practices find that self-administered questionnaires can expedite care tremendously, and some patients find it more comfortable rather than being asked all the questions. The example on our screen here allows the patient to complete some key info while waiting to see a provider. It may be obvious, but before recommending specific screening tests, the nurse or clinician still may have to ask some clarifying questions. While these types of tools can be translated into any language, we should still be sensitive to the fact that some patients may have visual impairments, limited literacy, or not be able to complete questionnaires for other reasons.
Yep. Using a questionnaire is what we do in my practice. We are fortunate that we have an electronic kiosk with an iPad that all patients go to when they check in. It asks a number of questions about past medical history that patients can fill out, including a basic sexual history. We ask if the patient has ever had sexual contact, how many partners they've had in the preceding 12 months, the sex and gender of their partners, and what kinds of sex they have. We offer that in our 3 threshold languages, but our medical assistants are also trained to ask the same questions during triage if the patient speaks another language or needs assistance due to disability, literacy level, or difficulty using the kiosk for any reason. Then the medical assistants use standing orders to collect and order specimens for screening.
So Shannon, can you explain what you mean by standing orders?
Sure. I love standing orders. These have been a real game changer in my practice. What we've done is I've written a universal order that applies to all patients in my practice that medical assistants can follow, allowing them to collect blood, urine, rectal, and pharyngeal swabs for testing for chlamydia, gonorrhea, HIV, and syphilis. The medical assistants use age, sex, patient request, and the history that the patient has provided to determine which anatomic sites are appropriate for specimen collection. They can do all of this during triage prior to my seeing the patient. The MAs then use an order set in our electronic health record and click buttons based on patient responses. The MAs also provide the patient with written educational materials about the tests they're getting, safer sex practices, and STIs, which the patients can read while they're waiting for me to come into the room. I often can do my clarification and counseling part of the visit in just a couple minutes when the MA utilizes all of these tools. For example, if a 21-year-old cisgender female patient completed a questionnaire and endorsed monogamous oral and vaginal sex with one male partner over the past year and, say, intermittent condom use, the MA could utilize a standing order similar to what is seen on the screen, and there would be orders available for HIV, syphilis, gonorrhea, and chlamydia for them to select.
And depending on how intricate your EHR is, you can even have multiple order sets with decision trees. So for example, I use a pregnancy order set, a different set for routine sexual and reproductive health visits, and a different set when patients come for PrEP, HIV, pre-exposure prophylaxis visits.
We've sort of hinted at workflows, but I should mention these in greater detail. Kind of like order sets, your office or health center can create flow diagrams or protocols to streamline care related to STI screening. For instance, you can have all patients give a urine sample when they are first having their vital signs done or being roomed. It's often a lot faster to do that up front, even if you end up not needing the urine for testing. You can also make sure all rooms have test kits ready to go, such as packs containing swabs for oral, vaginal, or rectal specimens right there in the room. In my practice, anytime an MA sets up a room for a pap smear or pelvic exam, they also put out swabs with patient labels for endocervical sample collection. So it's really easy to just add on some testing while doing a pap.
There's pretty strong evidence showing that patients self-collected urine, vaginal, and anal specimens, but possibly not pharyngeal, are as sensitive for STI screening as are clinician-collected specimens. We would recommend having pictures stored somewhere in patient rooms or in the restroom or on a computer station desktop that can be quickly shown to patients so they can see how to self-collect without having to read through detailed explanations.
And remember, every clinical encounter is an opportunity to close care gaps. You have to squeeze it in wherever you have the opportunity, because not all patients will take the time to schedule an appointment specifically for routine preventive health care. If you streamline the processes so it's easy to do and your staff are expecting it, you can add on STI screening to a diabetes visit, an asthma evaluation, or even a nursing home visit.
Yes, don't forget your nursing home patients. Older patients are extremely or frequently sexually active and need to access STI screening just as much as anyone else.
Maybe even more in my experience. Remember that sex is a normal human activity across the lifespan.
True. Shannon, these days I'm doing a lot of telehealth and remote care. Do you have any tips for making sure we do appropriate STI screening even when the patient isn't right there with us?
Sure. I think the most important thing is to still think about STI screening as a normal part of a visit, even if you're doing telehealth. Then figure out all the workflows so it's still an easy thing to do. In my clinic, we order all the labs in a telehealth visit, and then we can have the patient either go to our local commercial lab to have samples collected, or they can stop by our clinic to have blood drawn and urine collected, and our medical assistant can assist them with collecting pharyngeal samples and instructing the patient on self-collection for rectal and vaginal swabs.
Another important thing to remember is that STI screening doesn't always have to be associated with a clinical encounter. Just like with things like diabetes or cancer screening, you can also consider using your entire clinical team for population care. With standing orders, you can empower a team member, like a case manager or nurse, to reach out to patients who are due for screenings and order the test without requiring them to have a clinician visit.
And use your technology. Depending on what systems your practice uses, you may be able to send messages through your patient portal or text through a secure messaging system to remind your patients about completing their STI testing.
Well, this concludes the last of our three-part series on STI testing. We hope some of these ideas are helpful for you for looking at ways you can make STI testing an easy part of your everyday practice.
The key is to set up the systems in your practice such that it's really easy for you to just add on some STI testing to any encounter. Remember that if it's burdensome for you to do, you aren't going to do it consistently when faced with all of the challenges and issues of clinical care. The right thing to do has to be easy. And if it's not easy, look at ways to fix that. Use all your tools, technology, workflow changes, and your support staff to take the burden off of you as a clinician.
We hope you found this series helpful. If you haven't already, also check out our other two segments on taking sexual history and evidence-based screening guidelines for specific populations. And happy STI screening.